Dr. Anderson completed her medical education and residency in OBGYN at Vanderbilt University, and shortly thereafter moved to Johns Hopkins, where she is currently the Director of Gynecologic Specialties and a professor in the GYN-OB department, and I still don't know why Hopkins does it in that order. She is also the founder and director of their Women's HIV program, and the editor of a guide to the clinical care of women with HIV, which is a standard reference for the care of women. She has served on the U.S. Public Health Service panel on treatment of HIV-infected pregnant women and prevention of perinatal transmission since we started having such a panel. Is on the CDC HRSA Advisory Committee on HIV, viral hepatitis, and STD prevention and treatment. She's a senior advisor at JPIGO, which means she does this internationally as well as locally. And I owe her a personal debt of thanks for having been my mentor in all things HIV and creating the model of HIV care that we imported when the midwives came to Maryland. So thank you.
Good morning. Thanks, Jan. It was really our loss and your great gain when Jan and her colleagues left Hopkins and moved across town. So it's a real pleasure to be here with you this morning. I'm going to talk about elimination of mother-to-child transmission of HIV, and I'm calling it an unfinished success story. This is sort of the new term. It's not just prevention of mother-to-child transmission anymore. And I want to say that this talk is, and the program we have at Hopkins is sponsored by the, I'm going to get it wrong, but the Johns Hopkins HIV Women, Infants, Children, and Youth collaboration, which is funded by HRSA through the Rhine-Wide program, Part D. And I don't have a disclosure slide. The only disclosure I have is that I do have some stock in Gilead Pharmaceuticals. These are my objectives for the next few minutes. I want to first of all just review the current epidemiology of HIV and mother-to-child transmission, discuss missed opportunities for prevention of mother-to-child transmission and why we're not quite to the elimination threshold, review some basic principles about management of HIV in pregnancy, and discuss some new challenges in HIV prevention. I like to start with this slide because I think it sort of summarizes some of the huge successes sort of cumulatively in the management of HIV in this country. This is the trends from 1987 through 2013 in annual age-adjusted rates of death due to HIV infection in the U.S. And you can see that it was steadily rising up until the mid-90s and then dropped precipitously and has been dropping more slowly since the late 90s. And this is partly, mainly is due to the ability to better treat HIV with highly effective combination antiretroviral therapy. So this is a success story, and it's now believed, studies show that if an individual is diagnosed with HIV and they're diagnosed fairly early in the course of their disease, they get on therapy fairly quickly, that their life expectancy is near normal. This is looking at the rates of women of childbearing age living with HIV. So this is looking really at prevalence. And the main thing I like to point out is we live in a very high prevalence area, which I think is no secret to most of the people here. Keep in mind that prevalence, if you compare prevalence now to, say, prevalence at the height of the HIV epidemic in terms of death rates, prevalence is actually probably higher because incidence continues, and incidence among certain population groups actually is increasing again, such as men having sex with men. But incidence is also quite high in Baltimore among African American women. In fact, it's as high or higher than the incidence of HIV in certain African countries. So infections are continuing to occur, but also people are living longer. And so the prevalence increases. This is a slide that I show just to point out, because I think many people still have a stereotypic view of HIV infection, and they think it's usually due to, among women, to injection drug use, whereas the vast majority of cases at all age groups is due to heterosexual transmission. And what that means is that many women don't know that they're at risk, because their risk comes from their partner. If they don't know their partner's status or their partner's risk behavior, then they may not know that they should be tested, and their providers often don't think of it as well. And this is looking at the number of childbearing age women diagnosed with HIV by year in the U.S. and territories from 2008 to 2014, and it's looking at the age breakdown. You can see at the far right in 2014, the majority are in the 25 to 34 year age group, but there's a substantial number who are older than that and younger than that. So this is an estimate. We don't have good statistics from this, but this is the estimated number of births to women living with HIV from 2000 to 2006. And the bottom line is the best estimates we have suggest that it's around 8,000 to 9,000 women giving birth each year, and that's been about a 30% increase since the year 2000. So let me turn to the issue of mother-to-child transmission. This has truly been one of the biggest success stories in the whole HIV epidemic. The baseline transmission risk prior to treatment or without treatment is in the range of 25% in the U.S. And you can see on the left-hand bar, which is the Women and Infants Transmission Studies from 1993. So this is a natural history study. Then you see the next year, it had dropped by about 2/3. And that is due to the success of the ACTG-076 study, which was the first clinical trial in pregnancy of an antiretroviral drug, which was AZT or zidovudine, and showed that given alone to women in pregnancy, during labor, and to the infant for 6 weeks, decreased the transmission rate by about 2/3. And this was very rapidly translated into public health practice. It was really an amazing time to be in this field. So that's the ZDV era. And then you see continued decreases, and it's not related so much to clinical trials, because there haven't been very many clinical trials of antiretroviral treatment in pregnant women because of various concerns about treating or testing in research studies in pregnancy. But what happened is, as we got better treatment, we got more drugs. We discovered that combining drugs was really the key to a successful treating of HIV and preventing resistance. Then women were treated, and then they became pregnant. So they came into pregnancy on these different drugs. And so the latest statistics we have are from the UK, published in 2011, which showed in a large group in the UK, including Ireland, Scotland, that the transmission rate was only 0.5%. That's with the use of combination antiretroviral therapy. And so that's what I tell my patients today. If you're pregnant and you are on effective treatment and you have sustained decrease or optimal decrease in viral load to undetectable levels, your risk of transmission is less than 1%. So this is the diagnoses of perinatally acquired HIV infection in children in the U.S., again, over a 4-year period, 2008 to 2012. And again, you can see that Maryland and D.C. have high rates. And that goes along with our high rates of HIV infection among women of childbearing age, in which we lead. We are number 2 in the country. One of the things that's really important to know is that there are huge racial disparities among individuals with HIV and among perinatally infected cases. So that African American women are at higher risk of being HIV infection as the epidemic stands now in the U.S., and therefore for those women of childbearing age, they are more likely, those who have HIV are more likely to be African American, and the risk of transmitting HIV to their infants is higher. And so I think it's a huge challenge as we try to eliminate this, to really look at what are called hotspots around the nation, and to look at particular groups where this risk is significantly higher. So I wanted to turn to the issue of missed opportunities. Why is there ongoing transmission? We know how to prevent in almost all cases. Well, one issue is the issue of identification of HIV. As I mentioned, women may not know they're at risk. Their providers may not consider them at risk. If you look, this is looking from 2012 data. If you look at infants who were infected versus those who were exposed but not infected, and you look at the timing of when their mothers received an HIV test, you can see a big difference. Those who weren't infected, about 3/4 of them already knew their status before pregnancy, and then most of the rest were tested during pregnancy. You can see that of infected infants, only 38% knew their status coming into pregnancy, 17% were tested during pregnancy, and then the remainder were tested either at birth or after birth or unknown. So you've got to know somebody's infected, obviously, to be able to offer them interventions to prevent transmission. And this is looking at the timing of antiretroviral administration and how that affects transmission. So you've got to know the mother's infected, and you've got to know, then you've got to implement an intervention. And I think the key, this is kind of a busy slide. Let me see if I can point out just if you look again at infected infants and exposed but not infected, and you look at just this line, you can see that about 1/4 of those infected infants had no known, of this group, had no known antiretrovirals. You look at all the different time periods where antiretrovirals could be given, and at each time point, the later the administration of antiretrovirals, the more likely the infant was to be infected. So again, prevention of mother-to-child transmission of HIV is really one of the major success stories in medicine, not just in HIV, in the last 25 years. In the mid-1990s, there were approximately 1,750 HIV-infected infants who were born annually. In 2014, it was down to 127. And the latest statistics I've heard from 2015, and I don't think they're published yet, is 69. infants in the entire U.S. And again, as I pointed out in an earlier slide, during the same time period, there was approximately 30% increase in the number of women with HIV giving birth. So we really can talk about elimination. And when people talk about elimination, the CDC talks about elimination being defined as incidence less than 1 per 100,000 live births, and including a transmission rate of less than 1%. And I think Cuba was the first country in the world to document elimination of prevention of mother-to-child transmission. This is from a press release from New York in about a year ago, and Governor Cuomo announces the next phase of the state's plan to end the AIDS epidemic. Over the last 12 months, for the first time since the HIV epidemic began, New York State had 0 reports of HIV/AIDS infections passed from mother to child. And they attributed this to high rates of viral suppression among HIV-infected women and the quality of New York State's newborn screening program. So we think that we are within reach as a nation, and I think certainly in this state and in this region, to eliminate perinatal transmission, but we still have some real challenges. So this is, I think this is a useful prevention cascade, and I want to thank Steve Nesham from the CDC for sharing this with me. But on this side, it talks about missed opportunities and on the other side, prevention opportunities. So again, you have to know, well, I guess first of all, and I'll say a little bit about this later in the talk, but you don't have to worry about perinatal transmission if you prevent HIV among women and girls. And we still have a long ways to go to achieve that. Then you look at opportunities once someone is infected, and you want to talk to a woman about pregnancy. You want to give adequate preconception care and family planning. So it's important to engage her about her childbearing plans. If she wants to prevent pregnancy, then you want to give her appropriate contraception to prevent pregnancy. If she wants to get pregnant, you want to engage her around things that you can do and that she can do to optimize her health. I find that in preconception care, which I'm doing a lot of now in this setting, HIV is often the least of the issues. I'm seeing women who have all sorts of other medical problems which are either related or unrelated to HIV. You want to then make sure that when she gets pregnant, she has accessible, affordable prenatal care that's welcoming and non-judgmental. There should be universal HIV testing, which is routine and opt-out, which is allowed in this jurisdiction, so it should be really part of their prenatal test. They should be informed that this is a routine part of care. They can refuse, but if they don't refuse, then it's automatic. It doesn't require a separate consent form as it used to when we first started doing this. Then you've got to provide antiretroviral prophylaxis to all women. And then I'll say a little bit more about mode of delivery, but utilizing cesarean delivery in certain very, I think, limited circumstances for the purposes of mother-to-child transmission, avoidance of breastfeeding, and then comprehensive services ongoing. So if you look at then on the left side, the missed opportunities, women don't get tested, so they don't know they're infected. They know their status or don't know their status, but they don't have preconception care, which is another opportunity to determine status. They become pregnant, perhaps unintended. They don't have prenatal care. That's a missed opportunity. Or they have prenatal care, but they don't get tested. They get tested, but they don't have adequate prophylaxis and treatment. They need a cesarean delivery for prevention, but they don't get it. They have all of that, but then they breastfeed their infant, and then the child becomes infected. So we have a lot of opportunities to interrupt this cascade. So in a couple of studies, talking specifically about missed opportunities, between 2005 and 2008, there were missed opportunities to prevent mother-to-child transmission in about 3/4 of the infants who were actually infected perinatally. And very recently from Georgia, and it's sort of ironic since Georgia is the home of the CDC, but a retrospective review of infected infants in the state of Georgia from 2005 to 2012 found 27 cases of perinatal transmission in that time period. 3/4 knew their HIV status prior to pregnancy, but only 50% of those missed opportunities had prenatal care. 52% received no antiretroviral therapy, and only 3/4 of the infants received ZDV prophylaxis as newborns. Missed opportunities, furthermore, just to mention a couple of other things that I think are important to mention. Why do any transmissions occur if we're so good at treatment these days? Well, one reason is likely maternal genital tract infection. That could be herpes, it could be gonorrhea, it could potentially even be something as innocuous as bacterial vaginosis. But we know that if there is a genital tract infection, there can be a discordance between genital tract HIV RNA and plasma. So someone can have an undetectable plasma viral load, but they're shedding virus in their genital tract, and then if they have a baby who's born vaginally, that baby is more likely to be infected. One of the things that's gotten more attention recently, and in Maryland as well as around the country, is the problem of acute HIV in pregnancy, so new HIV infections. So this would be somebody who is negative at the time they're first tested, say in the first trimester, and they become infected later in pregnancy. We know that that's associated with a significant increase in mother-to-child transmission, probably for two reasons. One is that they may not be identified, so they have no sort of treatment or prophylaxis. And secondly, the nature of primary or acute HIV is that the viral load goes very high with primary infection. Then it comes down, even without treatment, to sort of a set point as the body's own immune system sort of kicks into play. But we know that the viral load is perhaps the major factor in transmission. We also know that pregnancy appears to be a time of increased risk for HIV acquisition. There are several studies showing that in the U.S. and in Africa. And some of that may be due to sexual behavior, that women may be less likely to use condoms in pregnancy because they don't think if they were using condoms primarily for contraception. But there's also some evidence that even when you control for sexual behavior, that this increased risk continues and is probably hormonally mediated. And then the major final common pathway, again, is the lack of early and sustained control of viral load. And to adequately suppress and sustain viral load in pregnant women and in other individuals with HIV, they have to have access to the most effective regimens and avoid treatment interruptions in pregnancy and maintain good adherence. So a little bit about some of the data looking at viral load and perinatal transmission. As I mentioned, the risk is directly proportional, the risk of transmission. Again, in a population-based transmission study in UK and Ireland, over 12,000 women, you can see that women who had undetectable viral load, and at the time of this study and with the assays they were using, that was less than 50 copies per milliliter. Most of the tests we use now are less than 20 copies per milliliter. But the risk was only 0.9% with transmission. If it rose to just 400 to 999, which is not that high, but it increased the risk of transmission to 2.6%. They also noted that earlier initiation was associated with greater decline, and other studies have shown that, and that if you had optimal suppression, there was no difference by mode of transmission. So it didn't matter if they had a vaginal delivery or C-section. None of the 2,600 HIV-exposed infants were infected when their mothers received a combination antiretroviral therapy. We used to call this HAART, highly active antiretroviral therapy. This is sort of the new term, which was initiated before conception, and they had a viral load that was undetectable at the time of delivery. So again, early diagnosis, early treatment, and with an effective regimen and good adherence. When we look at the timing of mother-to-child transmission, this has been elucidated for many years now. We know that the majority of transmission occurs sometime around the intrapartum period. We don't know exactly when. But about a third of transmission occurs sometime earlier in utero. But again, we think the majority of that is late pregnancy. And so you have about 3/4 peripartum, about a third to a quarter to a third in utero. That's without antiretroviral drugs, that your risk is 20 to 25%. If breastfeeding occurs, and particularly if it's prolonged, it can basically double the risk. And I'm going to come back to the issue of breastfeeding because that's become actually more and more controversial. And I'm certainly seeing, and you may be as well in some of your patients, women who are anxious to breastfeed with HIV. So I want to go over just a few of basically big picture principles for the management of HIV in pregnancy. And these are based on the U.S. Public Health Service guidelines. These are updated on a regular basis. They are at least once a year and more often when key things occur. And there is a conference call of this committee which includes OB representatives, pediatric representatives, adult representatives, federal government, CDC and NIH representatives who meet by conference call monthly. So just to the way the rating scheme goes is there's a strength recommendation, which is ABC, strong, moderate, or optional, and then what that recommendation is based on. So it's the quality of evidence. If it's 1, it's the highest level. It's a randomized clinical trial with clinical outcomes and or validated laboratory endpoints. If it's 2, it's not randomized clinical trial, but it's a well-designed trial or an observational cohort with long-term clinical outcomes. And 3 is based on expert opinion. So I think we have, and again, this is from 076, antiretrovirals should be initiated in all HIV pregnant women, regardless of their CD4 count or viral load. And this includes combining antepartum treatment, interpartum treatment, and then infant antiretroviral prophylaxis. Consideration should be given to initiating CART as soon as HIV is diagnosed during pregnancy. because earlier viral load suppression is associated with a lower risk of transmission. This is actually a change in the last few years in the guidelines. It used to say, you know, wait till after the first trimester. And I think a couple of things have happened. One is the data showing the earlier the better. And secondly is our comfort level and our experience in using these drugs, and the safety of using these drugs has increased. Now again, somebody who comes in with hyperemesis or just severe morning sickness is probably not a good candidate to start immediately. So there is some leeway here where your judgment needs to be used. But in the absence of any particular problems, and as soon as the woman is ready, because keep in mind that many women are first learning that they have a serious chronic lifelong condition in pregnancy. So they're very excited about pregnancy, and then they learn they have this life-threatening disease. And they do need time. Pregnancy is considered a relatively urgent time for starting therapy. But at the same time, because adherence is so critical, it's important to really engage the woman around this and make sure that she is ready and will take the medications. In general, we use the same regimen as recommended for non-pregnant adults because that's where the clinical trials showing effectiveness have been. And that's true unless there are known adverse effects for women, their fetuses, or infants that outweigh the benefits. You think about a lot of different things when you choose a regimen, including other medical conditions, convenience, which is a big deal, adverse effects, and keep in mind that some of the adverse effects of antiretrovirals, particularly early in the course of treatment, are very similar or synchronous with adverse effects related to pregnancy. Have to think about drug interactions, resistance testing results, pharmacokinetics in pregnancy, and our experience with use in pregnancy. And I'm going to say a little bit more about some of these. The PK changes in pregnancy are important to know because with some of the drugs, there are decreased blood levels in late pregnancy, probably related to metabolic changes and just a plasma volume expansion. And so it is generally recommended that you increase the doses or, in some cases, more frequent dosing. And this especially applies to protease inhibitors. I've mentioned just in passing adherence several times, but I think this is an absolutely critical piece of treatment. We know that if somebody has hypertension and they stop taking their hypertension drugs, then their hypertension is not going to be controlled. But if they start those drugs again, they're going to work. Or if they take them intermittently, they may get some effect. They'll get a better effect if they start taking them every day. The problem with antiretroviral drugs is that this virus is pretty smart, and it is very mutation prone. And if you have viral load levels that or have plasma drug levels that are fluctuating, which allows some rebound viremia, then the virus is going to mutate. It's going to develop resistance to that drug. One of the problems is that even though we have a lot of drugs to choose from now, is that often that drug resistance is across the entire class or most of the class. So you're not just developing resistance to one drug, but maybe several drugs in the same class. Furthermore, that resistance is lifelong. It doesn't go away. And many of the women that I have cared for over the last several years who have died of HIV died because they ran out of options. They had used up all of their drugs and they had multi-drug and multi-class drug resistance. So I can't overemphasize the importance of adherence, taking the drug as prescribed without missing doses. It is recommended that antiretroviral drug resistance studies, these are genotypic resistance studies, should be performed at the beginning of pregnancy if the viral load is in the greater than 500 to 1,000 or higher range, unless the drug resistance studies have already been performed. This should be performed before starting therapy or before modifying therapy if somebody is not fully suppressed, because if you are more likely to be able to detect resistance. If the viral load is too low, you can't rely on the results. You can still start therapy early while you're waiting for the resistance results to be available, and then just alter the regimen if needed. In general, HIV-infected pregnant women receiving CART who present for care in the first trimester should continue treatment if they're already on treatment, assuming that their regimen is tolerated and it's working. And by working, again, fully suppressed viremia. And this also is a change in recent years. Many of you may know or may not know that one particular drug, efavirenz, is a teratogen. It was a teratogen in primate studies. There have been reports in human studies of cases of neural tube defects or other serious CNS abnormalities. And so for many years, we were like, pregnant women shouldn't be on efavirenz. Women who want to get pregnant shouldn't be on efavirenz. Women who are of childbearing age shouldn't be on efavirenz. That was sort of a standard mantra for many people. Well, a couple of things. Well, one major thing happened is that efavirenz became one of the leading regimens used in the developing world to treat people with HIV. And so there became suddenly this huge experience with women who were on efavirenz-containing regimens, got pregnant, and then had babies. And we found that the risk, even though it's not to say it's not a teratogen, but the other piece in any drug in terms of its teratogenic effect is how often does that occur? And it occurs very rarely in the setting of women who are exposed to efavirenz in the first trimester. So at this time, the recommendation is if they come into pregnancy, they're on an efavirenz-containing regimen, continue that, assuming, again, that it's working and well tolerated. And I don't expect you to memorize this or to know this, but this is just a list of the currently available antiretroviral drugs. And you can see that there are 5 major classes of drugs, and then you have these pharmacokinetic enhancers, which improve the pharmacokinetics. So, you know, we started out with just one, zidovudine, and you can see that the pipeline has been very active over the last several years, and this is important. Many drugs now also are able to be combined into one pill, so that you may have 3 drugs, or in one case 4 drugs in one pill. And the simplest regimen now is 1 pill once a day. Back when zidovudine was first available, it was like 5 pills 5 times a day. And then as you added on drugs, you had more and more pills. It's much simpler than that now, which is, I think, obviously aids adherence. And again, I don't think you need to memorize this, and I'm going to, at the end of my talk, have a website which contains, this is again part of the U.S. Public Health Service guidelines for initial antiretroviral therapy in antiretroviral naive pregnant women, so women who haven't been on antiretroviral drugs. And they're divided into preferred, alternative, insufficient information, and do not use categories. And this is something that keeps changing. Primarily, the alternatives keep moving year by year, some of them to the preferred category, and that's because it's based on experience, our experience of safety and effectiveness. It's also it's based on what we know of pharmacokinetics in pregnancy. So as we get more information on the alternative side, we start saying, okay, well, now we can say this is a drug that you can really use without any concerns. You can see that actually in the non-nucleoside versus transcriptase inhibitor category, efavirenz is actually the preferred drug now, with a 2 nucleoside backbone. So usually it's the regimen is at least 3 drugs from at least 2 classes, and that's, if you think about how we treat TB, it's sort of the same principle. You're trying to hit the virus at different points in its life cycle. And then some of the newer drugs, inevitably, we don't have any data. Again, this is for women who haven't been on treatment. If they come in on one of these drug regimens, we don't generally change it if they're doing well on it. And then there are certain drugs or combination of drugs that are not recommended, and this is primarily because they've been superseded by better drugs. They had more adverse effects, things like that. Let me say a little bit more about acute HIV infection. When I mentioned that this is maybe one of the major reasons we are continuing to see perinatal transmission in the U.S. So you should have in your pregnant patients who have tested negative in pregnancy early on, you should have a high level of suspicion. If they develop certain signs and symptoms, which unfortunately are pretty nonspecific, sort of a mono-like illness, but you should just think about it. It's harder to think about it in flu season because there can be different symptoms, but you should always think about it. And if you consider it or you are suspicious, then you don't get a standard HIV test, you get a plasma viral load or HIV RNA test, because there's a window period before the standard test, which is antibody, or more in the 4th generation antibody antigen test, before those become positive. If you have a woman who's HIV negative, but her partner is HIV infected, and I think it's increasingly incumbent upon us to talk about this with our patients and to encourage that their partners be tested as well. CDC recommends that for everybody. Then if they do have a partner who's infected, consider the use of pre or post-exposure prophylaxis for them. Repeat HIV antibody testing in the 3rd trimester is recommended for pregnant women who have initial negative HIV antibody results, who are, and here's the categories, known to be at risk of acquiring HIV, receiving care in facilities that have an HIV incidence among pregnant women of at least 1 per 1,000 per year, are incarcerated or reside in jurisdictions with elevated HIV incidence. And guess what? That means everybody here in Maryland. And many of you may know, many of you may not know, that in this last session of the Maryland legislature, House Bill 180 was passed, and that requires that all pregnant women be offered HIV testing, repeat testing in the 3rd trimester of pregnancy, again on an opt-out basis. And this brings Maryland into really compliance with current guidelines from the CDC and from ACOG. Again, Maryland ranks 2nd among the states in HIV prevalence among women, and this was approved by the governor in May of this year. And I will mention that in the last 5 years, there were 7 perinatal transmissions in Maryland. 2 of those were in women who had negative testing in early pregnancy. So this is a real issue. And even though we think about Baltimore City as being the nidus of HIV disease in Maryland, and we do have high numbers in the city, but if you look at the surrounding areas, those cumulatively actually have more HIV cases than the city. I just wanted to mention that we are, and this is part of the success story, but it's also part of the challenge. because we are better at preventing transmission and better at treating HIV, so we have a cohort of young women who were perinatally infected themselves but have survived to adulthood and to the age of sexual majority and are now having children of their own. Again, this is a success story, but it's a challenge because many times these women have been exposed to suboptimal regimens, so they have a lot of drug resistance. It's also a challenge because in many cases they grew up without their parents. One or both parents died of HIV. They often grew up in foster care and have a lot of psychosocial challenges. So it's important to know this, and I think they need special attention. And this is a study from 2007. By the age of 19, of those perinatally infected young women who were sexually active, a quarter had been pregnant at least once, and some had 2 or 3 pregnancies. This is just what I was saying. We have limited data on pregnancy in these young women who are perinatally infected. They do appear to have a lower CD4 count. They are less likely to have full viral suppression, so they're more likely to require C-section. They have more drug resistance. But with appropriate management, there is no evidence that their risk of transmission is increased. So monitoring during pregnancy, we monitor the viral load at the initial visit. If you're just starting therapy, you want to monitor it more frequently until they're suppressed, and then at least every trimester. And it should definitely be assessed late in pregnancy, usually about 34 to 36 weeks, because that helps inform your decision about mode of delivery. When there is lack of viral suppression, you want to assess adherence, you want to perform resistance testing, and you should consult one of your HIV treatment experts as to whether or not treatment needs to be modified. Women should continue on their antepartum regimen during labor. That's a lot easier since often it's just once a day or sometimes twice a day. And even if they're going to have a scheduled C-section. IV AZT or zidovudine should be administered, particularly if the viral load is over 1,000. This is from the guidelines. But there is, in the current iteration of the guidelines, if they have an undetectable virus, you don't have any concerns about adherence, you can omit that. We've made the decision at Hopkins just to continue it to sort of standardize care. We don't see a lot of downside about that. Women who present in labor and they have unknown status should be tested, have rapid testing, and if it's positive, you start antiretroviral prophylaxis with zidovudine. You can, if their confirmatory test, which will come back after they deliver, is negative, obviously, you can stop. So the current recommendation is that if the viral load towards the end of pregnancy is greater than 1,000 copies, then you want to schedule a C-section. And you do it at 38 weeks rather than 39 weeks for other indications, and that's to try to prevent them going into labor. The data shows that it's scheduled because there has, in older studies, no evidence of good benefit if you delay until after labor has started or ruptured membranes. So again, it's not routinely recommended if they've got an undetectable viral load. The guidelines say HIV RNA less than 1,000. Again, that was the cutoff in testing when the studies were done. We actually are a little bit more aggressive than that. And then the infant should receive prophylaxis. I'm not going to go into this in detail. We know about, I think, the 6-week ZDV prophylaxis. Infants who are at higher risk, though, either because their mothers didn't get get treatment or prophylaxis, or maybe they received intrapartum prophylaxis only, or their mothers didn't have adequate viral suppression, et cetera, et cetera. The current data, and this is in the current iteration of the guidelines, is that they should receive a combination of zidovudine and nevirapine. And it's 3 doses of nevirapine in the first 96 hours. Let me say a little bit about breastfeeding. Why do we still say breastfeeding shouldn't be done when treatment is so good at reducing and viral load? Well, we're concerned about a couple of things. We're concerned because we know that there can be differential secretion of drugs into breast milk. So some drugs get into breast milk very well, others don't. And so you can end up, and this has been documented, having resistant virus in milk. And so if the baby is exposed, then they may be more likely to be infected. And if they are infected, they may more likely be exposed and infected with a drug-resistant virus. So you've sort of already decreased your ability to treat that infant effectively. I think one of the reasons this has become more controversial is not only because of our success at treatment, and we realize that treatment definitely reduces the risk in breastfeeding transmission, but it's also because we're seeing a lot more immigrants from lower resource countries where breastfeeding is the norm, it's the cultural norm, and it's also recommended even in the setting of HIV because it's associated with less neonatal and young infant morbidity and mortality. That's not true in the U.S. where we have safe water, we have easily accessible and affordable formula. But I think that increasingly I've been convinced we can't be really hard line about counseling because, you know, we make certain assumptions that women are, that they are telling us what they're doing and that they're using replacement feeding exclusively, when in fact, particularly if they come from certain cultural groups, perhaps they haven't disclosed to family or friends, they may be breastfeeding intermittently, which actually increases the risk. And yet they may not tell you this. So I think we are missing some opportunities by hardline counseling and not allowing women to vocalize her preferences and really educating her about the reasons and to help her to be honest with you. So starting with a non-judgmental question, what our recommendation is, and asking her just openly, is this a problem for you? And then talking about what her concerns are and exploring how you can counsel her and support her better. I mentioned at the beginning about prevention of new infections. Reduction of new infections also requires reduction of perinatal transmission also requires reduction of new infections among women. Prevention of unintended pregnancy is a priority. We know we don't do well with that in the U.S. in general, where about 50% of pregnancies are unintended, and we do even less well, I think, among HIV-positive populations. And I thought this is important to highlight. Even in the U.S., HIV is still associated with a significant increase in maternal mortality in pregnancy or in the immediate postpartum period. And we also know that adherence is a significant problem, particularly in the postpartum periods. So women need particular support at that time. So family planning, preconception care is important because of this, high rates of unintended pregnancy. We do have a lot of couples who are discordant. You may not know that HIV actually has an adverse effect on fertility, but then their fertility may increase after they start treatment. And then we also know that there's a high rate of comorbidities such as depression, interpersonal violence, which may affect maternal and fetal health. And the current studies show that the desires and intentions regarding fertility among women with HIV is really no different than the rest of the world. I'm going to, because my time is running short, but I do think preconception care is very important. And I mentioned the importance of assessing the partner status and engaging around if the partner is, if the woman is negative or partner is positive, talking about treatment as prevention. We know that treatment as prevention, if the man is on effective therapy, the woman's negative, the risk of transmission to her drops by at least 96%. Many people think it's closer to 100. And then pre-exposure prophylaxis is also available. We should also be assessing women who have HIV, their childbearing plans and desires on a regular basis, and the timing of those desires so that we can give appropriate counseling and support. This is the U.S. medical eligibility criteria for contraceptive use have just been updated in July, and the bottom line is that all of the available methods are acceptable for use in the setting of HIV. Spermicides are considered that the risks outweigh the advantages because of it may increase the risk of transmission. But in terms of the other methods, they are all, including the IUD. These are the websites. The website at the bottom, the AIDS info, is where all of the U.S. Public Health Service guidelines for treatment of HIV reside and are updated regularly. So not only for pregnant women, but for non-pregnant adults, for kids, prevention and treatment of opportunistic infections, and prevention of occupational exposure. And would encourage you to report cases of prenatal exposure to antiretroviral drugs to the Antiretroviral Pregnancy Registry. That's how we get most of our information these days in the absence of clinical trials, if there is any signal for a problem with, particularly with birth defects. So take-home messages. HIV incidence remains high in some areas and among certain populations. Prevalence has increased as death rates have decreased. Heterosexual transmission is the leading means of HIV acquisition in women, and many women and their providers don't know that they are at risk. But perinatal HIV transmission, less than 1%, and I would say much less than 1% are possible, but we do have key missed opportunities. Primary among those, lack of testing, occurrence of acute HIV in pregnancy, lack of effective treatment, and lack of infant prophylaxis. Prevention of unintended pregnancy and preconception counseling are critical needs. This is our program staff. We are available for consultation, but I think you have plenty of very excellent consult providers here in both the OB service in pediatrics and in the adult HIV service. I'd like to end with a slide. This is a patient of mine and her daughter. They've given permission to use this. The mother has been a counselor in my program for over 20 years. She was diagnosed with HIV when her daughter was diagnosed as an infant with HIV. She did not know she was at risk. Her daughter, this is an old picture, so she told me the other day, I got to get you a newer picture. This was the first baby that I delivered personally who had perinatal HIV, and her daughter is now completing her training as a nurse practitioner. This is a real success story, I think, of in terms of this disease. Thank you very much for your attention, and I'm happy to answer questions or to hang around because I know the time is you may have other things to go to, but if you have questions, please ask. Thank you. Yes.
Based on what you're
Mm-hmm.
How is that data collected? How does that
That was old data. Part of it, and again, that's without breastfeeding, and that's without treatment. So these were early studies in sort of the natural history, and they looked at the testing results in with infants. You can't use until they're at least a year old if they're not breastfeeding. You can't use antibody tests because the antibodies are across the placenta, so you're testing for the maternal infection. But it used to be using HIV DNA, we now use RNA. And looking at those tests when they became positive, if they were positive at birth, it suggested that they were infected earlier in pregnancy. I don't remember, because again, this is 20 plus years ago, the exact details of the studies, but there have been numerous studies that have suggested that. Yes?
There are some studies that suggest that HIV virus increases the
Yeah, so there are some studies, and I think that again, to repeat that, to suggest Depo-Provera may increase the risk of, particularly of acquisition of HIV. And the CDC has had a special ad hoc panel that addressed that, and there are some issues with those studies in terms of confounding, but I think that the bulk of the studies suggest there may be an increased risk. So, however, we know that there's also an increased risk if you get pregnant. The CDC came down on the fact that this did not mean that HIV should not be, that they still are, the benefits outweigh the risks of using Depo-Provera for contraception. But I think it should be part of the counseling. It should talk about the use of safer sexual practices. So it remains controversial in terms of the facts, but I think we have to accept that the bulk of the studies do suggest there may be a slight increased risk. Yes.
So given the success of PrEP in heterosexual men and sexual workers, and the fact that pregnancy increases the risk of transmission, why limit PrEP to just women who have a partner with known HIV positive?
You don't have to at all. I think that they're obviously at probably the highest risk if they're having regular exposure to somebody who they knows HIV positive. But women who are heterosexually active and who may be having multiple partners, certainly women who exchange sex for drugs or for money are extremely high risk. So I'm not suggesting it's only those. And I think a controversial area is PrEP in pregnancy. Right now the CDC doesn't recommend that, but we actually have a lot of experience with the drugs, which are a combination of emtricitabine and tenofovir, in pregnant women who have HIV, and I think it is reasonable in women who are at ongoing risk to use that in pregnancy. But Jan says you've done it here, we've done it. I think it's a discussion. The CDC is a little bit more conservative about this, but I think that's very reasonable. Yes.
One more question. Given that there are now Category B drugs available for treatment of Hep C, could the HIV model be used for several programs for prevention or preventive fetal transmission of Hep C?
I think that's a good question. I hadn't really thought about that. I think yes. I think that we obviously already have guidelines in terms of universal infant vaccination. So hopefully that'll be something we have that we don't have in the setting of HIV. But I think that for are you talking about Hep B or Hep C? Oh, Hep C, I'm sorry. So Hep C, yes, I think so. Right now, we don't have, though, really the experience using the newer drugs in pregnancy. So the current recommendations are not to treat Hep C in pregnancy. I think as we go on, it's going to probably follow the HIV course. We'll get more experience just by treating women. And of course, the treatment course is circumscribed as well. So there may be some similarities and some differences. But right now we don't have the experience and safety data that I could really say those drugs should be used in pregnancy. Any other questions? Okay. Thank you very much.